all the bells and whistles.
Yes. All right. Hello, everyone.
All the bells and whistles.
Yes. Are you getting an echo? All right.
Mm-hmm.
Hello, everyone.
All the bells and whistles.
Are you getting an echo? All right. Hello, everyone.
All the bells and whistles.
Okay. Hi. Is that better?
Yes.
I don't know what that was, but that experiment didn't quite work very well. Let me press record again, and hopefully that'll be better. Okay.
Yeah.
Hi, everyone. You're here for From Pain to Pleasure, the causes and treatment of pelvic pain and painful sex with me, Irene Fehr, and Rachel Gelman. Welcome. Thank you so much for joining us. We're excited to be here. We're excited to have this important and sensitive conversation. So first, I want to acknowledge your courage for taking this time and for first registering and then making the time to be here, because this is a sensitive topic and because it can really touch important things in us. So you are courageous for being here, and we hope that this is going to be informative for you and that it's going to help you know that you're not alone, and that there are resources for painful sex and for pelvic pain. A little bit on the logistical items of this webcast. So this is a one-way webcast, which means that all the participant cameras are turned off. So you do not have to worry about the privacy of being seen the other way. If you want to ask a question, or if you want to share that there's something happening, like you cannot hear, or there's an echo or something else, please use the Q&A functionality at the bottom of the screen and let us know, and we'll try to fix that as much as we can. We'll also be taking questions at the end of the webcast, your questions about pelvic pain, sex, pleasure, anything around this topic. And there is an anonymous button in the Q&A that you can use to submit your question anonymously. Again, we want to respect your privacy around the sensitive topic, and so please use that. We'll be answering questions that you guys submitted to us beforehand, as well as taking questions from the audience right now. And those questions will come at the end of the webcast. So here's how this is going to go. We're going to do some introductions first, and Rachel and I will talk about the different causes and treatment of pelvic pain and painful sex. Rachel will talk about the physical aspects of it, and I will talk about the psychosomatic ones and how they relate. And that's going to go for about the first hour, and then we'll take Q&A for the last 30 minutes of the call. And I'm going to check Q&A really quickly because, okay, that's a question. Awesome. Someone just submitted a question. Thank you so much. And it looks like everything is working. And be sure to stay till the end of the hour, because I'm going to be making an offer that's time sensitive that requires your response. So be sure that you're here before the end of the hour to hear that. And everything that we're doing here is going to be recorded and sent to you either tonight or tomorrow morning, depending on how technology works out. And there's always glitches and all that in technology, but you will receive the recording and have that for you to refer to. And lastly, I want to say again that this is a sensitive topic, and so I want to invite you to stay in touch with yourself, with your body, as we're talking about this, and check in what's happening for you. There may be emotions that may come up, there may be sensations, you may feel uncomfortable, you may feel scared, and so it's really important to check in and do a kind of self-care that your body is needing in that moment. So tune in, listen to your body, because that's really what we're here for as well, is starting to pay attention to our bodies and what they need. And so with that, I finish up the logistics. Again, if you have any logistical issues with a webinar, just use the Q&A button at the bottom of your screen. And now onto introductions. So who are we and why are we here speaking about this topic? So I'm Irene Fehr. I am an intimacy and sexuality coach, and I'm based primarily in San Francisco, but right now I'm actually coming from Colorado. And this topic and this webinar is really important to me because before I was a sex coach, I was a married woman who struggled with pelvic pain and painful sex, lack of orgasm, and general lack of sexual desire. And all of this culminated in my experience of having a sexless marriage. And when I was struggling with painful sex, I sought out help from the medical field. I was at the time a graduate student at Stanford University, and I went to the best of the best doctors. I went to gynecologists, I went to gastroenterologists, I went to a lung specialist to look for the causes of this severe tightness and pelvic pain that I was experiencing. A lot of it was just tightness upon entry, and then there was the pain during penetration as my husband's penis hit my cervix. And I searched all over for answers, and I got a good answer that there was nothing wrong with me. But I didn't get any answers on how to make my sex life better, how to feel better about myself, how to reinstate the intimacy that I had lost in my relationship because of this pain. And this problem preoccupied me for many years after this happened. And it contributed to me slipping into depression, me facing severe anxiety, that because this meant so much to me. It was my body, it was what it meant to be a woman for me. And so it affected me deeply. And I felt incredibly alone even as the doctors were trying to find that something was wrong, and alone in even just facing the problem because no one was talking about it. It was non-existent to talk about sex to begin with, and then to talk about painful sex, to lack of desire, all those things. And this personal journey that I went through led me to do work on my own sex life and realize a lot of things about my body, about sex, about intimacy, about pain and pleasure and sexual desire, and led me to do this work, the work that I do today as a sex coach, working with women who struggle in these areas and who cannot enjoy their sex life, to help them reconnect to their bodies, reconnect to their confidence, and to heal the intimacy in their relationship. And it was a calling, and it's my mission, it's part of my mission, to have these difficult conversations with women, with healthcare providers, and to bring solutions to women around this topic: pelvic pain, painful sex, lack of desire, and lack of connection to pleasure in our sex lives. And so that's what we're here for. That's what we want to have this conversation, and to acknowledge that this is a difficult topic, that this experience is incredibly hard, that it can have an emotional toll, that can take an emotional toll on you. And that the biggest message I want to say is that you're not broken if you're experiencing pelvic pain and painful sex. That some of it comes with the way sex education is done, the way we're taught about sex, and a lot of it is that this area is not getting enough attention. And so there's people like Rachel, who I'm going to switch to in just a second, who are here, who are doing this amazing work on the physical level and helping women and men to help their bodies respond better and to correct some of the muscular and hormonal dysfunctions that contribute to painful sex. So with that, I'm going to switch back to Rachel and have Rachel introduce herself and let you know what amazing work she's doing.
Oh, well, hello. So I'm Rachel Gelman, and I am a pelvic floor physical therapist in San Francisco. I work at the Pelvic Health and Rehabilitation Center. We actually have 5 clinics, 3 in the Bay Area, 1 in Los Angeles, and 1 in Boston, and I am the branch director of our office here in San Francisco. My background a little bit, I received my bachelor's in biology from the University of Washington, and then I received my doctorate in physical therapy at Samuel Merritt University. And I was fortunate enough to be able to complete a clinical internship in Austin, Texas at Sullivan Physical Therapy, where I did a clinical internship in pelvic health and pelvic rehabilitation. So that's a little bit about me. And many of you may be asking, as I get asked all the time by everyone, is what the heck is pelvic floor physical therapy? What does that mean? Obviously, they assume it has something to do with the pelvis, and that is definitely right and part of what I do. So it kind of helps to show you a pelvis so you can better understand what is the pelvic floor before I talk about what it is that I do as a physical therapist. So hopefully you guys can see my pelvis here. So here's your pelvis. This is the female pelvis, but men have a pelvic floor as well. I do see men and women here at the Pelvic Health and Rehab Center. So we're looking at the pelvis here. This is the front. You have your pubic bone. Then we can look at the back. That's your sacrum. And if we look from the front here, this is your clitoris, urethra, where urine comes out of, vaginal opening, and then down here is the rectum. Everything that's pink is muscle. This blue maroon portion that you hopefully can see is part of the glandular system in the vulva, so it provides lubrication to the vagina. And so there are these more superficial muscles towards the front that are around these different openings. And then if we look inside the pelvis, you have this muscular bowl. This is what most people when they're talking about the pelvic floor, this is what they're talking about. So there's this muscular bowl. These muscles attach at the front of your pelvis and at the back at your tailbone. And these muscles help support your pelvic organs. So for women, that would be the bladder, uterus, and the colon. And for men, that'd be the bladder, prostate, and the colon. So as a pelvic floor physical therapist, I'm treating men and women with anything from urinary dysfunction, bowel dysfunction, sexual dysfunction, as well as pelvic pain. Because if anything is going on with these muscles internally, that can lead to pain or dysfunction, just like any other muscle of the body. If it becomes restricted, tight, hypertonic, isn't functioning as well, is not getting enough blood flow, that can lead to pain and dysfunction. So I'm still going to be looking everywhere else in the body. But what sets me apart from other physical therapists is that I will be treating muscles internally. So either internal through the vagina or through the rectum for men, although I do treat some women via the rectum as well. So that's kind of what sets me apart from some of my colleagues who do more orthopedic physical therapy, although anyone who gets trained could do an internal exam. But that's, when you hear pelvic floor physical therapy, that's what sets me apart. And as Irene knows, I'm very passionate about educating and talking to everyone about not only pelvic floor physical therapy, but trying to provide everyone with good information about the body and about sexual health and women's health, because I feel like it is something that isn't addressed enough. And sex education is definitely lacking in this country, as well as I think internationally. So that's why I'll get off my little soapbox. But so that's why I'm here, and I'm really happy that I met Irene and she organized this webinar so we could hopefully get the word out about pain with sex and let everyone know, like Irene said, that there's nothing wrong with you, and there are people like myself and Irene here to help.
Yes, thank you so much. Thrilled to have you here, Rachel, and yes, bring the actual physical aspect to it so that people understand what's happening, and also that there are manual and physical healing methodologies to help them with that.
Mm-hmm. Yeah.
So I want us to start with getting to the meaty content about pelvic pain and painful sex with 3 myths that we hear a lot. As sex educators, as practitioners in this field, we hear this both in the media, like Rachel recently commented on an article, was it in the Cosmopolitan magazine or in
Glamour magazine,
about these myths that are everywhere about what creates good sex, what is good for pain, and that is actually contributing to the pain instead of making it easier. So let's debunk some of these myths. And the first myth is that if you have painful sex, you should be doing Kegels. You should be, Kegels are good for sex. They're good against pain. They're good for everything. So talk to us about that.
Yeah. So I'm always trying to figure out how Kegels became this like panacea for everything, and how out of all the like sexual health things, it's become the one thing that everyone seems to be comfortable talking about and throwing out. And I always get asked, or when I tell people what I do, everyone's always like, oh, don't worry, I'm doing my Kegels. And I'm like, ooh, well, you might not need to be doing Kegels. And the reason, so first let's go over what a Kegel is. A Kegel is a pelvic floor contraction. So if these muscles inside your pelvis contract like any other muscle, let me take it out here. So your pelvic floor muscles should be able to contract, relax, and lengthen. So a Kegel is a contraction of those pelvic floor muscles. So you might be thinking, well, that sounds great. Obviously, I should do a Kegel. Well, if those muscles are already contracted or in spasm or at their end range, just like any other muscle, if it's been stuck at this end point and you're trying to contract it more, you're basically just adding fuel to the fire and maybe causing it to become tighter, when in reality, those muscles need to lengthen or stretch. So I don't want it to sound like Kegels are bad, but not everyone needs to be doing Kegels. And if you're having pain, you probably don't need to be doing Kegels, and really you should go see a provider to determine if that's appropriate for you. Also, it's important to note, a lot of research studies have come out showing that most women were actually not doing Kegels correctly when they thought they were. And most women can't actually do a Kegel with just verbal cues alone. So I know I always hear people who are like, oh, I do my Kegels all the time, do them while I'm driving. I'm like, well, you might actually just be squeezing your butt, and that's pretty common. And really nothing else should be activating when you're doing a Kegel correctly. So, not only do most people not need to be doing them, but most people who think they're doing them are doing them incorrectly. And again, that can just lead to either causing more pain, or it can actually lead to pelvic floor dysfunction, because if you're constantly contracting those muscles and not letting them relax like they should, then you might be causing more restrictions to develop. So I think we live in a culture where we really want to be tight and toned, and that's something that we're really obsessed with. But I think everyone needs to recognize that being tight is not necessarily a good thing. What is a good thing is having good quality control over these muscles and having healthy, normal muscle tone.
And I want to add to that too, that so many of my clients come to me because they can't relax, and they're doing their Kegels, and they like you said, they're tightening up, but they actually don't know how to relax. And so the whole experience of penetration and other types of sex, such as oral, is always kind of like this. Like I'm just kind of like laying there all tight, and I cannot let my body go. So that's super important, like you said, is to have that range so that you can tighten up and have that muscle tone, but then you can also fully relax and fully let go, so that you can also enjoy that.
Yeah, exactly.
Which leads to the second myth, which you already touched upon, which is that you need to be tight and toned, and we're going to have better orgasms if we're tight, and that's just the fashion of the times is to have a tight vagina.
Yeah, and it's always interesting because I hear that a lot, like do your Kegels, you'll have a better orgasm, you'll have a deeper orgasm. And I always try to find the research behind this. And because I'm like, there has to be some research that shows that a Kegel is going to cause a better orgasm. And I haven't been able to find any good quality research that shows that direct correlation. I definitely could see how having better awareness of your pelvic floor, and once again, more range of motion. So if those muscles can fully relax and then contract and fully relax, which is basically what happens when you climax or have an orgasm, these muscles contract, relax in succession. So if you had more range of motion, I could see that could lead to a better, more robust orgasm. But again, it's about the range of motion, having that contract and then the relax. And I think making sure you're mindful, if you are really hell-bent on doing Kegels, that there needs to be a let go. Just like anything else, what goes up must come down. So So yeah, I haven't been able to find any good quality research. If anyone has some, they would like to send me, I'd love to see it. But, I think having the awareness would definitely help with sexual function and sexual appreciation. But again, it's all about having that range of motion and having a relaxation in response to the contraction.
And to add to that too, a lot of women complain about orgasm not feeling very nourishing or energizing. Like they'll have an orgasm, it'll feel good in the immediate moment, and then it actually feels depleting. Mm-hmm. And I believe that there's a correlation to having to induce the orgasm by tightening up, by really like focusing, by making it happen. And that is an orgasm, all right. And the kind of orgasm that you can have when you actually can relax and have that full range can be a much more nourishing experience, because it's something that you build up and develop and cultivate in your body rather than make happen. Yeah. And that becomes available when you have that range of tightness to relaxation, and then your body can build up that energy inside of you.
Mm-hmm. Yeah, I think trying to remember that having an orgasm shouldn't be this, prize. Like, obviously it's great and it feels good, but having sex shouldn't necessarily be about reaching this gold medal at the end, and instead trying to enjoy the experience while you're in it versus trying to get to this end point. Because I think when you put so much pressure on yourself to have an orgasm or have your partner orgasm, it can sometimes take away the fun of the event.
Absolutely. And we teach the body that, hey, sex is not that exciting or pleasant, and that creates kind of a cycle of not really wanting it, or having the body be responsive to it.
Yeah, definitely. So our other myth, which I hear a lot as well, is once you start penetration, you're going to be fine. Just grin and bear it. And if you just start having sex, even if it's painful, you'll get turned on and you'll be fine. And just go with it, even if you don't want to be having sex, or if it's painful, just keep going with it.
Yeah, that's a huge one that I hear all the time as well. And here's the truth about that is, first, if we're not turned on during penetration, or as penetration is starting, our muscles, not only our muscles are tight, but that there's no blood flow to the whole area. And when there's no blood flow, there's no elasticity or stretch available in the tissues and the muscles. And so if you're starting with that, you're basically starting from pain. And I'm going to talk more about this feedback cycle that gets created between our body and our nervous system and our emotions. But basically, if you're starting from a painful position, your body is it's registering that, hey, this is painful, but we're going to do it anyway. And it creates, then the next time you go into penetration, your body braces because it had a negative experience before. However positive there may have been, that you may have felt pleasure or things like that, it still creates a cycle that the body recognizes as painful and doesn't want more of it. Our bodies are very smart that way. So when there's no arousal, there's no elasticity and expansion, and so there is more risk of tears. There is also more risk of having your partner's penis or toy or finger bump up against the cervix and create pain, because when without arousal, the vagina is about 3 to 4 inches long or the deep. With arousal, it grows twice or even sometimes 3 times as much. And so if you start with painful sex, you will most likely create that in your body. And so this is a dangerous one to do, to disregard your body is not ready, that your body is needs more or is just not the time, and to do it anyway, because that creates that negative cycle. There's one caveat to this though, and Rachel does a lot of this work, is when you're trying to rewire the body to pleasure and using physical therapy or other practices, you want to push your body just a little bit more in a very slow and gentle and safe way. So this is like in a contained setting, in specifically working on having your body, penetrating, and then having your body relax around that, and using breathing, using mindfulness, using all these different tools that we're going to talk about in a bit. In that kind of setting, it's okay to keep pushing your body to go further and further. But the myth is about regular sex, like you're making out and you should just have sex, and that is a very, very dangerous and damaging kind of myth.
Mm-hmm. Yeah, going off of that, I mean, I definitely see a lot of patients who are coming in having pain with penetration, and when they decide they want to have sex, they feel ready to participate in intercourse with their partner. They often say to me, like, I'm nervous, I'm scared, but I want to have sex. I'm like, well, if you want to and you want to try, go for it. And then if you do experience pain, instead of, try to remain calm, basically, and communicate to your partner. And instead of immediately stopping penetration, trying to see if you can do some breathing and basically try to relax your pelvic floor muscles, which is something I would have already educated them how to do while working with them. And see if then you can continue. And obviously, if there's still pain, by all means, and you want to stop, by all means, stop. But again, going back to kind of retraining your brain, if you always go into a place of reacting to the pain and being like, oh my God, stop, we need to stop, your brain's going to learn this pattern, and your central nervous system is always just going to be very reactive. So if you can start to recognize when you feel the pain and see if you can train your body to relax, because sometimes what might be happening is your pelvic floor muscles are just tightening up and responding in a kind of a reactive way to your partner's penis, or whether it's a sex toy, finger. So just trying to work on that retraining of relaxation around sex and penetrative intercourse. So, I definitely don't think people should continue if they're having pain, but instead trying to relax and lean into what they're feeling and see if they can relax their bodies a little bit and then continue. And if not, then I'm always like, okay, yeah, don't continue, you should stop, and then, try again another time if you feel up to it.
Yeah. And communication with your partner is very important here too, having them slow down, having them adjust their position, or some other kind of adjustment. Mm-hmm. To help you be there in that moment.
Yeah.
Awesome. All right, so Rachel, tell us more about the different causes and the corresponding treatments for pelvic pain and painful sex. What contributes to it? What are some of the physical aspects of it?
Mm-hmm. Yeah, so there's a lot. And just for time's sake, I'm only going to cover a few. So I hope everyone knows that this is not meant to be a comprehensive list. This is not every single thing under the sun. Just the top ones that I tend to see as a physical therapist on a regular basis. So just know there are many other causes that if you have questions or concerns, you can always contact me later. We'll provide that information at when Irene sends you the follow-up email, if you do have questions or concerns. So I will discuss kind of the top few. So the first one is kind of musculoskeletal dysfunction. So as a physical therapist, what our bread and butter is working with soft tissue, muscles, nerves, and joints. So again, if we look at our pelvis, which right now is looking a little sad because I took away the pelvic floor, but you have your pelvis here and it's kind of sitting right at the center of everything. So you have all these abdominal muscles that attach to your pelvis. You have all your hamstrings, your glutes, your hip rotators. All these different muscles are all going to be attaching at your pelvis. So there are these external muscles that are attaching, and if they become dysfunctional for whatever reason, either they're restricted, they're in spasm, they've developed little trigger points or knots in the muscle, that's all going to cause lack of blood flow to the area. And even though you might be thinking, but it's my leg, why would my leg impact my vagina or my clitoris or my vulva? Well, the nerves that travel through the muscles can be compressed or irritated as a result of those restrictions. And those nerves can then send referred pain to other areas, even though it seems like it wouldn't be related. Nerves that travel through your legs also branch off and can go into the labia or the vagina. muscles that travel through nerves that travel through the abdomen, same thing, travel down your leg and can go into the vagina, the rectum, the clitoris. So I always am looking at the external structures in patients. I'm also looking at something called fascia. Fascia is connective tissue. It covers everything in your body, muscles, arteries, organs, nerves, what have you. And it kind of lays like a spider web. And so if it becomes restricted, it's going to inhibit blood flow. When things like blood flow, they lack oxygen. And when things like oxygen, they can get cranky and cause pain or dysfunction. So if any of these soft tissues that I'm talking about externally, as well as obviously if the pelvic floor muscles themselves, either those deeper muscles, I showed that pelvic bowl, or the more superficial muscles around the vaginal opening, become restricted as well, that's going to limit blood flow and those restrictions in general, they can become hyper irritated or irritable, and that can lead to pain as well. So that's the first one and kind of what I'm dealing with. So some treatment for that would be to obviously see someone like me, a pelvic floor physical therapist, to address those myofascial restrictions externally as well as internally. So I always tell patients, because not everyone can come see me in San Francisco. I wish they could, but they can't. Is if you're trying to find a good provider who does pelvic floor physical therapy, is they should ideally be looking not only internally, but externally as well. Because again, all these muscles are attaching at your pelvis. And when muscles share bony attachment points, they talk to each other. So if you have a tight abdominal muscle, that could be pulling on your pubic bone, and that could cause your pelvic floor to then be reacting as well. So it's really important to be looking all over the body, not just inside the pelvis. So that's the first one, is these myofascial or musculoskeletal dysfunction that can cause pelvic pain or pain with sex. And kind of going off of that would be a neuromuscular dysfunction. So like I said, these muscles should have a certain range of motion. They should be able to contract, relax, and lengthen. So if for some reason your muscles are not able to fully contract, relax, or lengthen, that can lead to things like the most popular one people think of is urinary incontinence. But it can also lead to pain, because again, if those muscles are going into this tightened state that you aren't able to control, most people might know that as vaginismus, they're going to be tight and nothing can get in. So that could be a penis, that could be a finger, that could be a tampon, and that obviously would cause pain. And it's kind of hard sometimes. It's like the chicken or the egg. Is the neuromuscular dysfunction causing myofascial dysfunction? Because obviously if your muscles are constantly going into this contracted state when you're trying to relax, then that's going to lead to restrictions developing over time. But then the reverse could be said, that if your muscles are hanging out in this restricted state, it's going to be hard to relax them. So they kind of go together. So things that I might do with a patient would be teaching them how to relax these muscles, retraining the brain, doing a lot of mindfulness, and basically working on relaxing the pelvic floor through these manual techniques, as well as through just education and what we call neuromuscular re-education, where I'm trying to teach the muscles how to relax and how to move through that range of motion again. And then finally, there can be a hormonal component. So if we look at the vulva here, so this would be the inner labia, and then you have the labia majora outside that is usually part that is covered with hair. This cream portion here is all mediated by estrogen as well as testosterone. So if there's a hormonal imbalance going on, and either you don't have enough estrogen in your body or enough testosterone in the body, that's going to impact all this tissue, as well as so the opening of your vagina, the urethra, the clitoris, as well as those glands I mentioned earlier that provide lubrication. So, if there's a hormonal component, which is not something that I will treat, I will refer to a physician to have those levels tested to see what's going on. So if those levels are in any way imbalanced, it can lead to pain with sex, because if this tissue is not getting what it likes, which is estrogen and testosterone, it's going to become less supple. It's not going to be as happy and healthy as it would like to be. And that can lead to things like pain, can lead to pain with urination, pain with penetration. Sometimes if people are having tearing with intercourse, it could be a result of lack of estrogen, testosterone. And most people associate like, oh, lack of estrogen, that's something that happens when you're old, when you're an old woman, you've gone through menopause, which is true. As we age as women, our estrogen levels are going to continually decline. And then we're in menopause and our estrogen levels are low. But lack of estrogen can actually occur after a woman's had a baby. When you deliver, your estrogen is at an all-time high. As soon as that baby's out, it's going to be at very low levels. So that's one instance when women might have low estrogen levels. And also, this is a new phenomenon that's come out, but the birth control pill can actually sometimes lead to these hormonal imbalances. The birth control pill, when you take it orally, causes basically your natural levels of testosterone and estrogen to decline. So sometimes if patients have been on the oral birth control pill for a long time, sometimes they might need to go off of it for a little bit, do some medications to help replenish their hormone levels, and that can help resolve the pain with sex. Again, I recommend if you're concerned about your hormone levels to go see a provider and get some lab work done to see what your levels are actually at. But that's probably the one that I don't specifically treat myself, but I see a lot of is people with hormone dysfunction. And sometimes people just have that for, there may not be a rhyme or reason. People who have endometriosis tend to have elevated estrogen levels, and people with polycystic ovarian syndrome, they have hormonal dysfunction as well. So there can be other disease processes going on that can lead to this hormonal component. And why I talk about this so much is because that change in the hormone levels is going to impact just this tissue. This tissue is becoming irritated. The surrounding muscles might become restricted. They might become hypertonic. And dysfunction can develop in the muscles as a result of this primary hormone dysfunction. So that's where I can come in, is to address this secondary myofascial dysfunction. But, you know, sometimes we need to address the primary problem, which could be a hormonal imbalance. So that's something that I'd recommend if you have concerns about your hormone levels, is to try to see a primary care doctor or a doctor that specializes in hormone testing to see what your levels are like. But those are probably my top three in terms of what I see in kind of the surrounding treatment. Obviously, everyone is different, but that would be like my little shindig of what I do as a pelvic floor PT, and the kind of top three things that I tend to see in practice. So.
And tell our viewers how they can get in touch with you, where they can find you. I know you introduced yourself in the beginning, but
did I skip that?
But again,
yeah. So again, if you're in San Francisco, that's where I'm located, at the Pelvic Health and Rehabilitation Center. If you're not in San Francisco, we have a clinic in Berkeley, a clinic in Los Gatos, clinic in Los Angeles, and one in Boston. If you're not in any of those areas, you're welcome to call our practice. I'll have Irene email out that information, but if you just Google, obviously if you're on here, you probably can hopefully can access Google, and you can look us up, the Pelvic Health and Rehabilitation Center, and you can always call our practice, and we keep a database of names of pelvic floor physical therapists that we recommend. There's also other groups that I recommend for finding providers that are knowledgeable about pelvic pain and pain with sex. One of those is the International Pelvic Pain Society, or IPPS. And then there's a couple groups that teach pelvic health courses to physical therapists, one of which is Herman and Wallace, and they have a database where you can search for providers in your area. And the other is the section on women's health through the American Physical Therapy Association, or the APTA. And they have a database of providers as well. But like I said, we always welcome calls from people. If you need to find a provider in your area, we have a giant database, and we are happy to provide you with referrals if you are not near one of our practices.
Awesome. Thank you.
Yeah. So Irene, would you like to talk more about what you see in your practice and some of the treatment techniques that you utilize?
Yeah, so my practice and my work focuses on the psychosomatic aspects of painful sex, the things that contribute to it, and then also the things that we what contributes to it also acts as a solution. So what is psychosomatic? So psychosomatic is whatever is, it's the connection between our mind and our body. It's our thoughts, our beliefs, our emotions, and the link to the body, the biofeedback loop that gets created. So first, I want to acknowledge too that anyone going through the issues that Rachel had mentioned, so be it the neuromuscular dysfunctions, hormonal shifts in your body that are affecting how the vulva and the vagina feel, as well as the different muscular dysfunctions, all of that contributes to a feeling of not feeling great, of feeling pain, and then also of the emotions that come with that, the sadness, anger, disappointment. And all of that, I want to acknowledge, can be very hard. It can feel like your body is betraying you. It can feel like you are broken and the cause of issues in sex and in your relationship. And that itself can contribute to that feedback loop that may not necessarily have caused the pain, although sometimes it does, but contributes to the pain, contributes to the body's response to that pain by tightening up and having the muscles in the vagina tighten up as well. So let me just break down this feedback loop that I see. So if you started with painful experiences of sex, if it could have been mild discomfort, or you have a history of painful sex, you also have the thoughts and the emotions that come with that. Fear, like what's wrong with me? What is happening? Why am I broken? There could be beliefs that are associated with that. All of that creates a response in our body that's really about fear, and it's about the nervous system goes into fight or flight mode. The nervous system, because our thoughts and everything is telling us that we're not okay, we're in danger, the nervous system gets activated, your heart rate may go up, your muscles tighten. And when that happens, the last place that gets blood flow is the genitals. We're wired to, if we're in fight or flight mode, to have our body get immobilized in the places that would save us from running away from the lion. That's definitely not the sex organs. That's definitely not our genitalia. And so when we're in that fight or flight mode, our body shuts down. We have less flow, less arousal. So if we go into sex from that place, we might have more painful experiences, which then again get matched up with fear and thoughts and beliefs that support that so there's something wrong with us, that we're not enough, that then create more pain the next time we have it. And so we create this cycle where the body starts to pair up sex, pain, kind of like Pavlov's response. So I see this so much with women who experience painful sex. So anything from their partner, just as innocent as a hug or touch on their shoulder, can have their body tighten up because they're anticipating that touch, that hug will lead to sex, and they will have pain. And that becomes just a huge cycle, a psychosomatic cycle that involves the body, the mind, and also in the nervous system. And so we start having this almost involuntary response. When someone touches us, the body braces up. And I see this over and over, and what contributes to it is three things. One is being in our heads instead of our bodies. So thinking thoughts like, I'm not enough, my body's not enough, if only I was taller, thinner, younger, I would be better, and just feeling scared of what that might mean. So when we're in our heads, we're not in our bodies, and our bodies then shut down. The second thing that adds to it is that penetration happens too soon. And since most of sex history, the way sex has been done for the last thousands of years, has been written by men. And men can have penetration much earlier and faster than women can. And a lot of women will have penetration at the rate of their partner, if the partner is a male, for example. Or just to please their partner. Their partner is ready, and it could be in a heterosexual or homosexual couple, going at their partner's rate and not going at the rate of their body. So just ignoring what their body is telling them. When that is happening, that adds to that feedback cycle, and reinforces this response that our bodies have, linking pain and sex together. The third thing is lacking connection with your partner or lacking intimacy. And I want to distinguish that from being attracted to your partner or loving your partner. Having that connection is something different here. It's about really being with your partner, being present, being felt and seen by your partner, and vice versa. And when that's not happening, what that creates is it creates lack of safety in the relationship. It creates this place where you feel alone and lonely there because you're by yourself and they're by themselves and you're not connected. And when our bodies don't feel safe, our bodies, women's bodies, will tighten up. And so that connection is really important. And again, if there's a lack of connection, it creates that feedback, the vicious cycle of pain and sex going together. And lastly, there's also patterns or behaviors that have come from previous trauma. So for example, I had a lot of vaginal exams growing up. I had a lot of urinary tract infections. I went to the gynecologist a lot when I was 5, 6, 7 years old. And so some of my first experiences around my genitals were about having the speculum stuck in me. And that just by itself, it wasn't trauma. They were trying to help me. There were adults present. There was no sexual abuse or anything. It was just very clean and innocent and simple. And the fact that that's how my genitals were first handled had me really tighten up. Like, that was not a comfortable experience. And so I could not reverse my body's reaction to tighten up when my genitals were touched, whether by myself or me. And so that can add to that cycle. And the solution is to rewire the body and the mind, and often the relationship, the intimacy aspect of it, for pleasurable experiences, and break that feedback loop. And you have to do it on several levels. The first level is listening to the body. The body will tell us what it needs, even if it's doing the opposite. Like, even if it's tightening up and it's not doing what you want it to do, it does send us signals. It knows when something feels good and something feels bad for it. And the thing is that we have to remove, and it speaks in tiny, soft whispers. We have to remove the loud voices in our heads that are telling us, no, you should do it, or, this is inconvenient. You shouldn't ask your partner to slow down, or you shouldn't feel this way. We have to separate these voices and start listening to the whispers in our head or not in our head, whispers from our body rather than our head, and start listening. And I use a lot of mindfulness practices and a lot of quieting down practices to help my clients tune into their bodies. And a lot of the practices around also removing those voices, those loud voices, those inner critics, and the fear voices that have us not listen to our body in the first place. And I often talk about having sex in a way that feels right to your body. All of our bodies are different. And it's about learning what is right for you and having it 100% of how you want it. And everyone's like, oh, 100%, that's crazy. Like, can't we just negotiate? Like, a little bit for me, a little bit for you? And I say, no, this is not an area to negotiate, because this is, again, if you are having something that doesn't feel good, even if it's just uncomfortable, you're teaching the body about pain. You're equating, like, the Pavlov's response, sex, pain, or discomfort, which can then soon turn into pain. So listening to your body is really important. Listening to your body's, for example, if your body's not lubricating, this is another kind of myth that I like to debunk. Everyone loves lube, and I think lube is wonderful. Lube is not a substitute for arousal, however. Lube can make things smoother. It can make things more pleasurable. It is not a substitute for arousal. So when you do not get wet, it's a sign to start listening to your body. Okay, what is here? What's going on for me? And listen to it, literally listening to also working with a pelvic specialist and having be in a container where you can actually feel the different ways that your body responds to touch in a safe space. So listening to your body is the first way to rewire your body. And then the second one is to start creating positive experiences, positive sexual experiences, so that your body knows what pleasure is, what is the opposite of pain, and have more of those. And this is really important. There's a lot of brain research that shows that we need as much as 5 to 7 positive experiences against one negative experience, because our human bodies are wired to register negative experiences more strongly, because we need to be able to run away from a lion when they're chasing us. So we're tracking negative things. We're not wired to say, oh, lion, excuse me, I'm gonna pay attention to these beautiful flowers and how they smell and how I love them. No, we really register the negative things. And so to rewire the body, we have to tip the scales toward the positive experiences. How do you do that? First is you slow down. You take a step back and you slow down, and you slow down the act of sex, you slow down the whole process, and you start feeling bit by bit, very similar to what Rachel mentioned earlier. If you are trying to relax when it's painful, you do it very slowly. You go in a little bit more, and then you breathe and you relax and you take time there, and then you go a little bit more. When you rush through that process, you create more pain. You create that negative feedback loop. Slowing it down is very important. And then the second piece is doing it through touch, healing through touch. Touch is incredibly healing. Healing for the muscles, for the tissues, and also it creates connection when it's done also in partnership. And I teach several practices to my clients. One of them is called orgasmic meditation, and it's a practice that is really about having creating a space for women to really relax and receive pleasure, and to know what that pleasure feels like in our bodies. There's also other things such as yoni massage or pelvic massage or vaginal massage that is also very important. It's about having the body really be in this receptive mode to pleasure. And of course, physical therapy as well. That is done in a very safe space. And the safe space aspect is really important because, like I mentioned earlier, when we don't feel safe in our relationship, that has our body contract out of fear. That's a natural response. And that's why the third point is really about rewiring ourselves to pleasure by also working on this in the relationship. So many women come to me saying, I'm broken, I need to fix myself in order to start having sex with my husband. And I want to shift that perspective to say that painful sex is not only your problem as a woman, it's a couple's issue. Not so much that it's a problem in the relationship as much as that the healing happens in that partnership. Whether you are a couple right now or you are going to be in a partnership eventually, that where you will need your partner to be there for you in a sensitive way around pelvic pain, that is going to be something that has to be done together. And in my practice, when couples see this as an us issue, when they tackle this together, they see not only pain-free sex, but they have and experience deeper intimacy and deeper love and deeper connection in their relationship. And in that, I teach couples how to do sex differently, to connect to each other. I call this connection sex, to connect to each other and to feel each other's bodies and to really be there for each other in a different way than just performing or doing the moves. And that itself can be very healing for the aspects, the psychosomatic aspects of this that are about safety, that are about being taken care of and felt and supported. And so those are the three areas that I'll mention again. So first one is listening to your body. The second one is doing this in partnership with intimacy. And the third is creating these pleasurable experiences so that your body can rewire itself, so that it knows more than just pain, and needing to tip the scale in favor of pleasurable experiences, however small they are, however gradual the buildup is, creating more of those in your body. And with that, we're almost at the hour. So I want to, before we switch to Q&A and take your questions, and we have lots that came in ahead of time. We have several that are here right now. I also want to mention that I am making 6 free consultation sessions available for people on this call to talk about what's happening for them, to explore options, and to leave a session with both clarity and support for next steps, whether it's working with me, working with Rachel, or working with another sex therapist or coach. And if you'd like to claim one of these sessions, please email me at Irene@irenefehr, Fehr.com. I'm making these available until September 1st, so for the next 2 weeks, and they usually go by fast, so respond as soon as you can. And with that, and wow, we're just like exactly at the hour.
I know.
As I'm frying here in the sun, but I didn't want to shift, but it's okay. I hope you guys can see my face as I'm like dodging the shadow. With that, let's switch to Q&A.
Yeah, we got a lot of questions. Like you said, submitted ahead of time as well as while we were speaking, which was awesome. And if we aren't able to get to all of your questions, Irene and I are going to try to send something out to you guys where we will answer all the questions that were submitted as well as submitted just now during the live cast, so we can make sure that we answer them all, but we may not be able to get to all of them right now as we only have 30 minutes left. But just so you know, we will get them all answered, even if we don't answer them right now during the live stream.
Awesome. So the first question we have, which we've received several along the same lines, is being in a situation where the woman's partner's penis is hitting the cervix, and that there's pain around that, and that like oftentimes he can only go in 2 to 3 inches before it starts hurting, or it hits the woman in her cervix, and creates pain. So Rachel, what do you have on that?
Yeah, so definitely, obviously I'm biased, but it definitely seems like she could benefit from seeing a pelvic floor physical therapist, just being able to determine if there are any restrictions in the pelvic floor muscles that could be causing her pain. I see a lot of women who come in with similar reports, feeling like their partner's hitting a wall or hitting their cervix. And actually, I'm able to reproduce their symptoms by just palpating maybe a hypertonic muscle or a trigger point that's in one of the pelvic floor muscles. So definitely, I think she would benefit from seeing a physical therapist or a pelvic floor specialist. And then, people ask me about positions. Sometimes if you're in a heterosexual couple, being on top can allow you to have more control over the depth and the speed of penetration. Sometimes being on your back, if you put a pillow under your pelvis, that can change the angle of things, which can make it so that you're not having maybe the penis hitting whatever at that angle, and that might make things feel better. or less painful. Sometimes patients find it beneficial to be in like a sideline position, which can sometimes prevent deeper thrusting. And, you know, so I guess that's kind of the biggest ones I can think of. It obviously sounds like she might have some, anytime someone's telling me they're having pain with sex, I automatically think there might be a myofascial or musculoskeletal component, and they could benefit from seeing someone like me or a pelvic floor specialist. And that's kind of the very typical patient that I see all day, every day.
And to add to that, from my perspective, if everything checks out on the medical level and on the muscular level, I would also look at the question of, how turned on are you when you're having sex? So as I mentioned earlier, when there's arousal, the blood flows to the genitals, and then the 2/3 of the vagina lengthen and then force the cervix to ascend and the uterus to ascend. And so you have a lengthening. And if you're not turned on, that lengthening is not happening. And so there can be a bumping up against the cervix. And so when that question comes up, like, how turned are you? How turned on are you when you're having intercourse? That's not just about lubrication, but I talk about this, having sex when your vagina is coming out to meet your partner, having sex when you like about to explode, having sex or penetration when your body is so ready, not just your mind. We often go by our mind like, oh, well, it's been 15 minutes and maybe I don't want to inconvenience my partner. I should be ready by now. We have a lot of this talk that has us think that we're ready, which may not be the case in our body. So the practice here is starting to listening to what the body is saying, what the body is needing, and following that and seeing how you can get turned on more in that situation. And like I mentioned, I teach several practices that help with that, such as orgasmic meditation and different pelvic and vaginal massages that help to bring more blood flow, more stimulation and turn on to the genitals so that there can be that arousal, that lengthening, and more readiness.
Mm-hmm. Yeah, awesome.
Here's a question that we have about specifically the effects of STDs on painful sex. So here's someone writing. So she was diagnosed with both herpes and HPV about 10 years ago, and she gets dry and finds that lube helps. She wants to know some basic sex ed questions. First, is it bad to use spit as lubricant due to bacteria, etc.? And she also writes, I'm almost always very tight and sex is painful most of the time. Does herpes and HPV contribute to painful sex? And, or is it just something that I need to accept?
Yeah, great questions. Spit can definitely be, is kind of like the first original lubricant, if you will, but it's not the most effective. I personally recommend a water-based lubricant. This question, she mentioned slippery stuff, which I think is a great option. There's tons of great water-based lubricants out there. So I either recommend a water-based lubricant. If you're not using condoms, coconut oil is another really great option. But I usually recommend something that has a little more meat to it, for lack of a better word. So a water-based lubricant, because spit's just not going to last very long. It's going to get absorbed. And, she's asking about bacteria. Things can be passed via saliva. So if you are concerned about STDs or transmission, I'd recommend not using spit, especially if you are having an active herpes outbreak or some sort of oral infection. It's just probably best to err on the side of safety and to use an actual lubricant. And then her question about if herpes and HPV can contribute to pain with sex, like all things, it depends. So HPV, there's so many different forms. Some can go away on their own, some can cause genital warts, some can cause cervical cancer. So off the bat, I'm always wanting to make sure that patients are having regular examinations just to keep an eye on things. If you have tested positive for HPV or had an abnormal pap, make sure you're staying on top of those examinations, because it can be managed if you do have a certain type of HPV, and you want to make sure it's being monitored, because if the disease progresses, it could end up causing pain with sex. And then with herpes, if you have an active herpes outbreak, and I assume that she's referring to genital herpes, obviously if you have an active outbreak, then that would obviously be causing pain. But even if you aren't having outbreaks, the herpes virus can remain in your body. And there are some case studies that show that the herpes virus that causes genital herpes and oral herpes could impact the nerves, similar to what shingles is. Shingles is a different type of the herpes virus, and it can impact the nerves and cause what's called postherpetic neuralgia. And there is some evidence that the herpes simplex virus 1 and 2 can also impact the nerves in that way and lead to this neuralgia. So there are medications that can help with this if that has developed. But I also recommend, seeing your healthcare provider, because there are antiviral medications you can be taking to help manage the herpes to prevent it from escalating to that level. But I mean, assuming that you're having regular checkups, you're managing the herpes virus with antivirals, the pain again could be from like a myofascial cause. If you have had these active outbreaks, once again, if that tissue is getting irritated, your muscles are going to go into this protective response and contract and try to protect you. That's what they're there for. They go into this like fetal position of protecting your vagina. So potentially you could have some myofascial dysfunction that could be addressed with pelvic floor physical therapy.
Great.
Yeah.
Here's another question. I'll read it. Sometimes when my pain levels are low, I decide to engage in sex. I end up getting pain during intercourse. But other times when I actually feel more achy and I engage in sex, there's no further pain, or even it disappears. Still, I have high levels of anxiety when it comes to sex, and I rarely engage in it, maybe just once or twice a month. What steps can I take to recognize better if I'm at risk of more pain during sex, or to reduce the chance of getting more pain?
Awesome. So this was a really interesting question. So potentially, if there's a restriction or a trigger point in the muscle that's in an irritated state and causing pain, your muscles then may be benefiting from increased blood flow during sex, which is causing the muscles then to let go and relax, which might be why. But on the flip side, if the muscles are in this relaxed state and then you engage in sex, the penetration could be irritating that restricted area, causing it to tighten up, and that's what's causing pain. So that's kind of what my hypothesis would be. Again, it would be awesome if this person could see a provider to do an examination to see what's going on with her pelvic floor and see if they can reproduce the pain with palpation. But that's kind of my hypothesis off the bat. So it's hard for me to say how to better recognize if you're at more risk of having pain during sex without doing an actual physical examination. So I'm going to sound like a broken record, but I'd highly recommend trying to see someone to do an actual physical exam. But that would be my theory from the physical standpoint. I don't know, Irene, if you have any thoughts for this writer.
Mm-hmm. Yeah, I'll speak to the anxiety aspect of this woman's question. She wrote, I have high levels of anxiety when it comes to sex and really rarely engage in it. Here, I would get curious about what is happening on the emotional and mental level in the times that you are having sex and there is pain, and the times when there is no pain. And just getting like a scientist, getting curious of like, what are the things that are happening on that day? What's happening inside? Do you feel turned on? Do you feel kind of full and alive, or do you feel tired and depleted, and are you having sex from that perspective? And just start tracking of what is happening and what can be contributing to the situation. And the second thing I want to say about when there's anxiety, the key is to slow it down. If you bulldoze over anxiety, that usually creates more anxiety. Anxiety needs, when you're anxious, it's about really paying attention to what's here and self-soothing and grounding yourself in the body and becoming calmer, becoming more grounded, more stable in yourself. And so when you go too fast through that, you don't have a chance to do that. So slowing it down for yourself, slowing it down with your partner, asking your partner for adjustments, whether it's position or something else, bringing your partner into this experimentation of seeing what is correlated with the pain. And also playing with taking the attention off of penetration and seeing and creating more positive experiences for your body. Again, breaking that link of pain and sex together, which then creates the anxiety because your nervous system wants to protect you. It thinks it's in danger because, of course, pain correlates with danger for a nervous system. So having more of these positive experiences that don't involve penetration, so that you start to fill up on pleasure and seeing if that will help.
Yeah, definitely.
So let's see, another question. And what time? I'm checking the time. Okay, so let's take one more question from the list. Is this one? So this is a question from a new mom, and of course there are a lot of questions from women who have children, because childbirth, and Rachel and I talked about this, like we don't talk enough about motherhood and childbirth and how important that is. So here's a question from a mother. I had my first child 4 months ago and had what I think was a 2nd-degree tear. I was cleared for sex at my 6-week checkup, but it's still very painful. Any penetration, even a tampon, hurts. Even a strenuous workout will irritate it. My doctor recommended estrogen cream, but will that actually solve the problem? From what I've read, it's mostly for lubrication, but that doesn't seem like it's my problem. Am I expecting my tear to heal too quickly, or has it been long enough?
Yeah, that is a great question. And this is a very common thing that I see as a pelvic floor PT. We see a lot of new moms, a lot of moms coming in, having pain with sex or just pelvic pain in general. Childbirth, whether it's vaginal delivery or a C-section, is a lot on your body. And I don't think, like Irene said, I don't think we recognize that enough, just how traumatic childbirth can be and how pregnancy in general is just a lot on your body. A lot changes, and that's 40 weeks of change and things happening to your body. So I know people think this 6-week checkup means that they should be back to their pre-pregnancy self. And, you know, I think that's a little unrealistic based on how many weeks of change occurred before you have the baby, and then just expecting 6 weeks to be completely back to normal is unrealistic. So off the bat, I would say the 6-week checkup is not meant to be a time when you're being told, like, yes, you are supposed to be 100% normal now or back to your pre-baby state. So that's the first thing, is just I want to just acknowledge that I think people have this idea that they should be back to normal after having a baby. And having a baby and being a mom, I think, is the hardest job. I joke that I'm not a mom because I don't think I would pass the first round of interviews. I think it's a really tough job, and it's basically like 17 full-time jobs in one. But having a baby is tough. So a vaginal delivery, having any tearing is pretty common. So once again, seeing a pelvic floor PT can help. We can address the scar tissue at the opening and actually teach you or your partner how to perform the scar massage at home, as well as treating any other restrictions internally and externally that may have occurred as a result of the delivery and the pregnancy. The estrogen cream, that I think can help because, again, this tissue and your tear occurred right through here. So it went through this tissue that's mediated by estrogen and testosterone. So, and now that you're postpartum, your estrogen levels are low, and if you're breastfeeding, they're going to remain low for a little bit longer. So using that cream is going to help, with lubrication, as well as helping bulk that tissue back up, making it less frail, less thin, and that can help with tissue healing. So I definitely think the estrogen cream is beneficial, but I think you need to come at it from different angles of addressing the myofascial component as well as the hormonal component, and also just recognizing that it's going to take time. I mean, some of the research shows that recovery after childbirth can take up to a year for some women. And because again, it's been 40 weeks of your body growing a person. And then whether you had a vaginal delivery and the tearing, or you had a C-section, which again is a very major surgery, there's going to be time needed to heal just from that process alone, and from all the physiological changes that occur as a result of being pregnant. So, I think give yourself time and space to heal, as well as see if you can find a specialist who can at least teach you how to do the scar massage, as well as address any of the myofascial restrictions that might be present. And obviously there probably is if you still have scar tissue. And I think that answers all of that question. Yeah. But it's very common, very common.
And to what you were saying too about how pregnancy and childbirth it takes a toll on the body, that the expectation to be back to normal within 6 weeks or even just a couple of months is a tall expectation to fill. And so to that I want to say too is that as you're getting back into being sexual, as in having intercourse, having penetration, to build up to it. So to start with other kinds of sex or practices to have that sexual connection, and to help your body also heal from the trauma. A tear is a trauma to the genitals. It creates scar tissue, and the body registers that there was something that something happened to that. And pleasurable touch, pleasurable sexual touch that does not have to lead to intercourse can actually heal the genitals, and it can create a positive feedback loop that, okay, there's pleasure, and you start associating pleasure with sex, rather than thinking that, oh, because I have a tear, it's going to be painful, I can't do it. So reinforcing the positive loop rather than the negative loop. And in taking it slow, when you do have intercourse, taking it extremely slow, using, making sure that you're very turned on, and then using extra lube so that you're not aggravating that area.
Mm-hmm. Yeah, and I think also recognizing, I see a lot of new moms who tell me, I went to the 6-week checkup and they told me I can have sex. And I'm like, why in the world would I want to have sex? And then they feel guilty about not wanting to have sex at this 6-week mark. Mm-hmm. And again, being a mom is hard. It's exhausting. So if you don't want to be having sex at that point, don't feel pressured to do so. By all means, if you want to be having sex, you should. But if you don't feel like just because your physician or your practitioner has told you, oh, well, you're cleared to have sex, don't feel like that means oh, I have to be, I should be. And don't try to not feel guilty, because it's very common for women to be like, why in the world would I want to be having sex? That sounds awful. And I'm like, you're not alone. So I just want to point out that don't feel like just because you are not interested means that you're behind the benchmark of where you should be, or that you're not successful. Everyone's different, everyone heals differently, and just don't feel pressured to have to be having sex at that point.
The more you honor yourself, the more you honor what your body is needing right now, or not needing, by saying no to sex, the faster you can heal, and the healthier you'll be in the long term. So yeah, so that guilt and that pressure or doing something that's not right for your body will doesn't help that. Okay. All right, so let's take a Q&A question live. Can you see that? So let me read that. So my partner complains that my penis penetrates too deeply. I've tried putting in just the tip, but both of us find this unsatisfying. Are there any devices that can help us? If so, what are they, and what is your experience using them? So this sounds like it's from either a male or a partner who does the penetration?
Yeah. That's a great question. There are some devices out there that I've heard of that kind of create a buffer between the person and their partner so that the penis is not able to go in as deeply. It's not available, at least the one I know of, which is called the ONUT, is not available on the market yet. So I don't know of any other devices, to be honest. But again, this could be a matter of positioning. So having your partner be on top so that she's in control of how deep she's going and how deep the penis is going into her. Or sideline, using pillows. Also, you could try, instead of having penetrative intercourse, using things like a vibrator. There are different types of vibrators out there now that provide both stimulation to the male and the woman. But otherwise, I'm not aware of any other devices out there. Are you, Irene?
And the first thing that comes to mind is just using the finger and seeing if the pain can be recreated. If there's insertion through the finger, and playing around with that. And if you can create a pain-free and a pleasurable experience with the fingers, seeing how that can be recreated with the penis during insertion. Obviously, there can be different girth, and obviously it's a very different type of material, but it's a way to kind of see if the what can be causing it. Is it the position? Is it something inside? Is it the rate of insertion or depth or whatever it is?
Yeah, and off of that, I mean, the partner, depending, could try using what's called a dilator, which is basically a medical device that's used to practice penetration on her own. Basically, I describe it as a medical grade dildo. And they come in graduated sizes. And if the person's penis is bigger than the largest dilator in the set, there is something called clone-a-willy, where you can make a dildo or a dilator that is the size of your partner's erect penis. And that way she can actually alone use that dilator or the cast of her partner's penis to practice on herself, so there's no pressure of another person being there. And that can sometimes help with this type of painless sex. So that is an option. I suppose if you wanted to get, your crafting hat on and get one of those kits, you could do that at home. But that's, I guess, the only device I can think of that's out there on the market right now is the clone-a-willy, so that way your partner could get used to or practice with a cast of your penis.
Awesome. So we have one last question. What do we do if one person's 100% comfort level sexually is very different than their partner's? So maybe I can answer that since I brought up the 100%. So I want to distinguish between having 100% alignment on what you want done sexually and what feels good, what kind of positions or what kind of acts, versus 100% on what feels right to your body. And when I say that, I'm talking about pain. So if something is uncomfortable for you, so whether it's penetration or oral or touch, it could be that the touch is too rough, too hard, too fast. If anything doesn't feel good to your body, 100%, as in it's not creating pleasure, it's creating anything below that. So it could be mild discomfort to pain to excruciating pain. If it's there, then you have the right to say, to have that stop. That is your body. That is about you experiencing what is done to your body in the way that feels right to you. And there may not be alignment, but this is not that area where we can compromise. We can compromise in terms of like the kind of acts, like I'm not as comfortable doing that, but sure, I can do that. Versus I'm not, this is creating pain. This is not comfortable for me. And when it's the latter, when there's pain, it's about really honoring yourself and saying no, and not negotiating on that, because that discomfort can very easily, coupled with guilt, coupled with fear of maybe losing your partner or being judged by your partner, can create physical shutdown and possibly pain later on. Rachel, do you have anything to add to that?
No, I think that covers it.
Well, we are just to the end of the 90 minutes. So thank you so much, everyone, for attending. You'll be receiving an email from me with our contact information and any follow-up questions. And please reach out to us if we can support you in any way. And hopefully this was an informative and webcast for you. And Rachel, do you have any parting words?
No, just like I said, we'll try to get answers to all the other questions. I think we covered most of them during our talks. But if you feel like we didn't answer your question, obviously you can reach out to us in the contact information that we'll provide. And yeah, just know that we are here to help, and there are people like us here to help. Not necessarily just me and Irene, but you're not alone, and what you're feeling and experiencing is common, whatever, even if someone's told you differently. But we are here to support you, and please feel free to reach out either through the information Irene sends out or on social media. And yeah, and thank you for joining us for our first webinar together.
Yes, thank you so much.
Yeah.
Bye.
Bye.